Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Symptomatic Profiles of 1,334 Polycythemia Vera Patients, Implications of Inadequately Controlled Disease by Holly Geyer et al. My name is Brady Stein. I'm an assistant professor of medicine at Northwestern University in Chicago, Illinois. I'm a hematologist, and my focus is on myeloproliferative neoplasms. At the close of the Polycythemia Vera study group in 1997, Dr. Nathaniel Berlin, an instrumental member, eloquently reported on the three eras of Polycythemia Vera. The first era, around the turn of the 20th century, was marked by initial descriptions of this new clinical entity by Dr. Vakhez and Osler, and later by the introduction of therapeutic phlebotomy. The second era saw additional refinements in diagnosis and therapy, including use of nuclear red cell mass to distinguish absolute and relative erythrocytosis, and reports on treatment with and subsequent consequences of radioactive phosphorus first emerged. In the third era, the Polycythemia Vera study group further refined diagnostic criteria and conducted pivotal clinical trials, raising awareness of the association between secondary malignancy and certain cytoreductives such as radioactive phosphorus and chlorambucil. During this era, hydroxyurea emerged, giving perceptions of a comparatively balanced safety and efficacy profile. In 1997, Dr. Berlin speculated that Polycythemia Vera was entering its fourth chapter, the molecular biology era, foreshadowing important new discoveries. Nearly 8 years later, the JAK2 V617F mutation was observed in the overwhelming majority of Polycythemia Vera patients. This discovery enhanced our understanding of the clinical phenotype of Polycythemia Vera, first described by Vakhez and Osler, and has greatly facilitated the diagnostic approach. Another key development in the post-JAK2 V617F discovery era has been the recognition that myeloproliferative neoplasm patients can suffer a considerable symptomatic burden with sometimes profound impact on quality of life. An instrument to systematically quantify this burden, perceived by the patients, evolved from an internet survey in 2007, which reported a high prevalence of fatigue, pruritus, night sweats, bone pain, fever, and weight loss, even in those Polycythemia Vera patients without objective features of high-risk disease. The latest iteration is used in the majority of modern myeloproliferative neoplasm clinical trials and queries 10 symptoms rated 0 to 10 in severity, which capture the burden of symptoms that are constitutional, cytokine-related, vascular in origin, or due to splenomegaly. The survey, used internationally, has helped hematologists understand that the Polycythemia Vera symptom burden is prominent, independent from traditional risk classification, and can rival in severity the burden brought on by other solid and hematological malignancies, including acute leukemia and myelofibrosis. Importantly, the molecular era has also led to expanded treatment options. While therapeutic phlebotomy remains a cornerstone of management and hydroxyurea remains widely used, not all patients tolerate these therapies or experience resolution of their symptom burden. Importantly, the JAK2 V617F discovery led to the development of a JAK inhibitor for a subset of Polycythemia Vera patients with active phlebotomy, splenomegaly, and inadequate response to hydroxyurea. The RESPONSE study, leading to approval of ruxolitinib in Polycythemia Vera, was conducted in patients with these Polycythemia Vera features and resulted in improvements in the Polycythemia Vera symptom burden, reduction in splenomegaly, and liberation from phlebotomy compared to those on best available therapy, such as hydroxyurea. In the article that accompanies this podcast, an international group of collaborators led by Drs. Geyer and Mesa review associations of these Polycythemia Vera disease features, including known phlebotomy use, palpable splenomegaly, and known hydroxyurea use, with the Polycythemia Vera symptom burden. The study included 1,334 polycythemia vera patients whose disease duration ranged from 6.5 and 11.5 years and had previously participated in the myeloproliferative neoplasm fatigue project and myeloproliferative neoplasm symptom assessment form validation studies. Patients were compared to other patients who lacked the particular problematic feature of interest. This latter group was considered as a control. Based on published criteria, the total symptom score was characterized as low, intermediate, moderately high, or high. Among the study group, 646 had known phlebotomy use, 499 had known hydroxyurea use, 369 had palpable splenomegaly, and 148 had all three features. Intuitively, patients with each problematic feature were more symptomatic compared to their respective controls. The investigators also confirm, as previously published, that the symptom burden was independent from a contemporary risk grouping. Those with even one problematic feature alone had a moderately high symptom burden profile, perhaps similar to the average symptom burden of patients with myelofibrosis. Also, as suspected, the presence of additional problematic features further increased the symptom burden. In fact, those with all three problematic features had a high symptom burden profile, exceeding the average score of a myelofibrosis patient. An important question arises from this study. Should we reevaluate the polycythemia vera treatment paradigm in 2015? Historically, the management of polycythemia vera has largely been based on modifying the risk of vascular complications, and cytoreductive therapies are added upfront for high-risk patients and often later in the disease course for traditionally low-risk patients with problematic features, including splenomegaly or frequent phlebotomy needs. The study by Geyer et al. Adds to a growing body of literature suggesting a prominent and potentially undermanaged symptom burden despite treatment with phlebotomy and/or hydroxyurea, even among traditionally low-risk polycythemia vera patients. One must take care when interpreting some of the study findings. The authors state that each problematic feature independently is associated with a substantial symptom burden. A reader may interpret this to mean that hydroxyurea and phlebotomy contributed to worsening symptoms. This would be accurate if it could be shown that these interventions contribute to adverse side effects that result in a higher symptomatic burden. Rather, this may suggest confounding by indication. An underlying severe disease may demand more aggressive therapy. My conservative interpretation is that polycythemia vera is a heterogeneous neoplasm and that cornerstones of management may not adequately address symptoms for many polycythemia vera patients. This important article suggests the necessity to think more broadly about indications for and choice of therapy. In 2015, polycythemia vera treatment should be individualized with decisions based not only on vascular risk, but also on systematic assessment of the burden of symptoms and their impact on quality of life. In other words, one must look at both the subjective and objective burden of disease. This study also provides an important framework to critically evaluate indications for therapy and therapeutic options from the perspective of their impact on quality of life. For example, in polycythemia vera, there is emerging literature suggesting associations between adverse outcomes and leukocytosis, but whether symptom burden is more severe in those with leukocytosis has not been widely reported. If such an association is shown, this may provide even further justification to reduce the leukocyte count. Interferon alpha is an emerging therapy in polycythemia vera. Associations with the polycythemia vera symptom burden, whether positive or negative, have not yet been systematically reported, but this is an important issue given that this agent is in advanced clinical development. In their conclusion, the authors raised the possibility for broader use of ruxolitinib in symptomatic polycythemia vera patients. At present, issues such as cost, lack of knowledge about long-term safety or impact on natural history, and lack of clinical trial data in those without hydroxyurea resistance or intolerance restrict use as a second-line agent. However, in this molecular era of polycythemia vera, at least options are emerging, and a change in the therapeutic paradigm will be welcomed. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.